My name is Barbara Cochran. I'm the director of the DeTourney Center for Healthy Aging here in the School of Nursing. And I also represent the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this lecture series with the support from HRSA, Health Resources Services Administration funding. And I do want to just mention yet again, please contact your site coordinator if you haven't filled out a profile form. We do need that information so that we can do, as we call it, bean counting and ensure that we continue to get funding for this excellent lecture series each year. Also, if you're interested in getting contact hours for continuing education, your site coordinator will have an information sheet that you can use to sign in online. It's actually a fairly reasonable cost, and you can sign in at the end of the series or in between, in the middle of it, but then log in for each of the lectures that you have attended. The lectures are also posted online on our center's website. So that website is www.nwgwec.org, and it's listed under the educational, what is it called? Other activities and geriatric healthcare series. There are actually over 70 lectures posted there. The series for this term are getting posted, each lecture is getting posted within a week of it's being presented. And so if you know of someone who is really interested in this lecture but couldn't attend in person or live today, within about a week they can download it and view it online. Today I'm really pleased to introduce Dr. John Gore. He is a urologist and urologic oncologist who specializes in male voiding dysfunction. He sees patients at the Men's Health Center, which provides opportunities to engage patients in state-of-the-art clinical care as well as ongoing research in lower urinary tract dysfunction. And he's a co-investigator for the UW research site of the NIDDK-sponsored Lower Urinary Tract Research Network, which seeks to better understand risk factors and therapeutic options for men and women with voiding problems. And today he's going to talk about benign prostatic hyperplasia. So welcome, Dr. Gore.
Thank you so much. So, in thinking about goals for this lecture, the things that we would think about would be trying to make sure that everyone out there managing men with urinary symptoms and BPH in particular has maybe a better handle and grasp on the medical surgical options available, as well as sort of a rational approach to evaluation in these patients. Do I just hit the...
I think you need to press the cursor. There's arrows down in the lower left-hand corner.
You should be able to press the arrows on the keyboard.
Oh.
Or the arrows on, yeah.
Okay, I can do that.
Okay. Can you see if the arrows work now for you? Yeah.
Okay. So if anyone ever has any questions about patient management, that's my email. Feel free to use it. BPH, or benign prostatic hyperplasia, is very broadly growth of the prostate that can cause urinary symptoms in men. BPH can be asymptomatic, but in general, because the prostate is, I would kind of classify it as sort of the epicenter of the genital and urinary tract, it causes a lot of problems when it becomes either enlarged or inflamed. Because it sits below the bladder, it can inhibit the flow of urine trying to exit the bladder. And so that's why as men get older and their prostate swells or grows, these symptoms become much more prevalent. Unlike the uterus in women, which involutes postmenopausally, the prostate just continues to grow and grow despite its functional irrelevance in older men, because it really is just a reproductive organ. In general, all men have changes in their urinary symptoms as they get older. The analogy I always give to patients is that I have two nephews who are teenagers, and so every time I see them, they've each grown like 6 inches. And my brother is always surprised because he sees them every day. So he has sort of accommodated to large magnitude changes because he's witnessing small incremental changes day to day. A lot of men don't realize that their urinary symptoms have changed really substantially over a 5 to 10 year period. The severity of the symptoms is not entirely predictable. In general, the bigger your prostate, the more likely you are to have bothersome urinary symptoms. But there are some intricacies to the anatomy of the prostate and the relationship of the prostate to the bladder that can affect the predominance of urinary symptoms. Oh, should I turn this?
Oh no, don't worry about that. I'm here doing support, so
okay.
I should be able to help.
Okay. And so, for example, there's one entity in BPH called a median lobe, which is where a growth of the back part of the prostate can grow up into the bladder and act as a ball valve, occluding the prostate, which can cause really severe urinary symptoms irrespective of the size of the prostate. And then a lot of younger men who have severe urinary symptoms don't actually have a big prostate, but what they may have is bladder neck hypertrophy, which is where the junction of the bladder and the prostate is just functionally narrowed, and that's the source of their urinary symptoms. But in general, the bigger your prostate, the more likely you are to have symptoms. A number of what we would classify maybe as non-urologic factors can also impact voiding function and impact the degree of bother that men experience as a result of some of the urinary symptoms they have. Fluid intake, so there are a lot of aggressive hydrators out there. And it's not just the quantity of the fluid intake, it can also be the timing of the fluid intake. So as an example, I'm on my feet most of the day. I don't usually have a bottle of water at the ready. And so if I go home at the end of the day, I've acquired a dehydrated state. And so if I'm making up for that at night by drinking 2 to 4 glasses of water, that's more likely going to lead to voiding in the middle of the night. Caffeine consumption is a big scourge for people with bothersome urinary symptoms, most notably symptoms like going frequently or having tremendous urinary urgency. And here in the Pacific Northwest, we see a lot of heavy caffeine users. And so you want to make sure you're querying not just about coffee, but also tea, soda, kind of all caffeinated forms. Life stresses. So before I came to UW when I was a fellow, I worked at the student center at the university I was at, and I saw a lot of young men with urinary symptoms as they were transitioning to graduate school or to new jobs, that these life stressors can lead to. You think about TMJ as a place where people kind of hold their stress or their bowels, and irritable bowel syndrome, but some people can hold their stress in their pelvic floor, and that can lead to urinary symptoms. Sleep has a huge impact on urinary symptoms. I refer a not insubstantial number of men every year for sleep studies for suspicion of undiagnosed sleep apnea, for example. And one thing that is a truism is that as we get older, our sleep quality and our ability to maintain ourselves in the deeper stages of sleep is much worse. And so sometimes what we're trying to disentangle is whether a man is waking up at night because an urge to pee woke him up, or whether he is peeing because another source woke him up. So is he awake because an urge to pee woke him, or is he peeing because he woke up? And so all of these things can interplay and affect urinary symptoms. Importantly, medications for BPH have really revolutionized the care of BPH. Back in the 80s, doing surgery for BPH, for big prostates, was number 2 only to cataract surgery in the Medicare population, and that's nowhere near true anymore. And a big reason why is we finally have effective medical therapy for BPH. But the degree to which medications are associated with symptom improvement is highly variable, and the sort of maximum magnitude of benefit for medications is limited compared with, say, surgical management. So how do we evaluate a man for the suspicion of BPH? Well, you can do some patient-reported outcomes. And so one of the commonest questionnaires we use is something called the International Prostate Symptom Score, or IPSS. The IPSS has 7 questions, and I'll show you some of those on the next page. And it also includes a quality of life question, so that you can look at their score, rating, the degree or magnitude of their symptoms, but also correlate that with the distress that patients experience as a result of their symptoms. For objective measures, because that's obviously a more subjective measure, for objective measures, you can do a urinary flow rate. So this is a device that most urologists have in their office, which is basically a funnel that sits over a canister over the toilet, and it quantifies the force of the urine stream and also quantifies the voided volume. And that allows you to see the pattern of voiding, and I'll show you some examples of that. Most offices, urologic or not, have a bladder scanner to assess post-void residual urine. So after checking the flow, we'll then do a quick bladder scan to see how much urine men leave behind. I often do a post-void residual as an initial screening test for really most men. And that's just to make sure that men are not in occult retention. And it's not uncommon that we find a man who endorses really mild urinary symptoms has a post-void residual over 300, and we have to have a more substantive discussion about bladder outlet obstruction and urinary symptoms. Urodynamics is an invasive test, and I'll show you some examples of that, that we use to try to better discriminate bladder function, to really understand if it's the prostate and bladder outlet obstruction that's the source of the man's symptoms, or whether it's actually the bladder itself that's the source of the symptoms. And these are all clinical tests. We use these tests really to try to identify the severity of the problem, but also understand which treatments are likely to be beneficial and which treatments are not. I always tell men that this is a quality of life problem. And so the degree to which men are bothered by this problem is really what is going to direct treatment. And so bother is really an incredibly important determinant about our aggressiveness with which we're going to manage BPH. So the IPSS has these 7 questions with a quality of life question. There are some ways that I ask about these things that I think are a little bit more patient-centered. So incomplete emptying is that sensation that you still have urine left in your bladder after you peed. Urinary frequency, so there are a couple different ways to ask that. You can ask it in terms of quantity of voids, so how many times do you pee during the day, but also in time between voids, which I think is more meaningful. So how often do you have to pee less than 2 hours after you just peed? And how often can you go 3 or more hours in between voids? Intermittency is the sensation that you have to stop and start your urinary stream. Urgency is that sense of having to rush to the bathroom and feeling concerned that you can't hold it, either because of pain or because you think you're going to have an accident. Weak stream and straining are fairly self-explanatory. And nocturia, or waking up at night to urinate, is something that is normal as we get older. And so you want to kind of try to normalize the degree of nocturia with the age of the patient. And so sometimes I'll get a 75-year-old man in my office who's complaining of nocturia once nightly. And so a spiel that I often use for that man is if they were in a room full of other 75-year-olds, the other men in the room would throw tomatoes at him if they found out he was only getting up, once a night. So it's important to know sort of age-specific baselines for some of these symptoms. Avoiding diary is something that we use periodically. I will say one thing about voiding diaries is they can be hard to interpret. In general, avoiding diarrhea assesses between 2 and 3 days of a man's voiding, and it includes how much they take in, so fluid intake, and the timing of fluid intake, which is one of the most important parts of the voiding diary, and then how much they pee, and with that void, do they have a strong urge to go, and is there any associated urinary leakage? I find voiding diaries to be most helpful among men with nocturia, just because we're trying to look at their pattern of fluid intake and their pattern of voiding, and see if that can guide any behavioral changes that might be associated with a reduction in their nocturia. So this shows you a couple of uroflows, urinary flow rates. So on the left, just comparing qualitatively the pattern of the uroflow. On the left, you see sort of a parabolic curve where upon initiating the urine stream, patients immediately void with a strong flow, and they have a fairly efficient void. And so they're able to complete their void in a fairly short order. The other thing that you look at is the maximum flow rate, and you can see the peak flow rate for this patient is around 35 to 40 milliliters per second, which is very unusual for a male patient, but which we see quite commonly among female patients. And that would be a normal uroflow. On the right, you see a uroflow that is consistent with bladder outlet obstruction. And what you see is sort of a staccato or sawtooth pattern where the maximum flow doesn't get above 10. Anything less than 15 is pretty consistent with bladder outlet obstruction. And then you also see a prolonged voiding time. So it takes this patient more than 15 seconds to try to empty. And then correlating that with the post-void residual. I mean, in most men that we're seeing for urinary symptoms, they're going to be over 50. And so ideally, I'd like that to be less than 100. But occasionally I see a 35-year-old man with urinary symptoms, and they may have a post-void residual of 75, but for a 35-year-old man, that's highly, highly unusual. We start to get concerned about anything that's over 200 or 250. Our guidelines about post-void residuals have changed a little bit. Reflexively, we used to get concerned about post-void residuals over 300 enough that we would start thinking about periodically catheterizing those men. So teaching them how to do clean intermittent catheterization or self-catheterization. But now, if that man is asymptomatic and has no signs of renal damage or impending renal damage like hydronephrosis, their creatinine is preserved, they don't get recurrent bladder infections or bladder stones or any of the sequelae of incomplete bladder emptying, we just follow those men really closely. Urodynamics is, like I said before, a much more invasive test. And what we do is we put a very small catheter into the urinary bladder and another small catheter into the rectum. And the reason we have a catheter in the rectum is that the pressure within the bladder is the sum of the actual bladder pressure, but also pressure external to that, which might be coming from like a Valsalva maneuver. So by having a catheter in the rectum, we can subtract out any Valsalva pressure, so basically a man can't fool the test. A man can't make the test seem like they're generating a high pressure when all of that pressure is coming from a Valsalva maneuver. So important things that urodynamics measure. Well, they measure contractility. How well does the bladder squeeze? So I'll give an example of a man I saw today. I saw a 64-year-old man with severe lower urinary tract symptoms who also has type 2 diabetes that is insulin dependent, which he's had for over 10 years. He has some neuropathy from his diabetes, so he's got some diabetes with end organ complications. And so that man has a high risk of having a bladder contractility problem. So before I subject that man to surgery, I want to know that his bladder squeezes well. So contractility is one of the main things we measure. Compliance, or how elastic the bladder is. So one of the main functions of the bladder is to just hold urine. And so can the bladder hold urine at safe pressures? Or as the bladder fills, does that pressure start to rise such that you're concerned that this is a man who has risk for renal damage from their bladder dysfunction? It helps identify men who have an overactive bladder. So as we fill the bladder, do we see spasms of the urinary bladder? And it also can document bladder outlet obstruction. So if we see the combination of a really strong pressure in the bladder, so a really strong detrusor pressure with a really low flow rate, that is really kind of pathognomonic for bladder outlet obstruction. High pressure, low flow. We don't routinely use urodynamics. So I recommended urodynamics on that man I just mentioned. But I do urodynamics maybe once or twice a month, and that is out of a large denominator of patients presenting with new urinary symptoms. What about other labs? I don't routinely check a creatinine. It's not part of our guidelines that are part of the AUA. If I have any degree of suspicion about kidney function, I will. We do routinely check a urinalysis. We're looking for other sources of urinary symptoms. Do they have sterile pyuria? Is there blood in the urine? Is there proteinuria, which might be a sign of some intrinsic renal disease? We don't routinely check a urine culture unless the urinalysis shows something that's concerning. And a PSA is optional pending a shared decision-making process. I would say for a urologist, I'm fairly dove-like about PSAs, but I do think the PSA is an important screening test. That's not part of this conversation. But it is really critical that men understand the implications of getting a PSA test. Because one of the biggest risks of getting a PSA test is having an abnormal PSA test. And one of the big risks of having an abnormal PSA test is getting diagnosed with a prostate cancer that doesn't need to be diagnosed. But I do at least talk to men about PSA, and we have a shared decision-making process about whether we should order that as part of their evaluation. So as you think about this pyramid of how we treat things, and as we ascend this pyramid, we typically, for a lot of chronic health conditions, especially ones that aren't life-limiting, think about behavioral interventions. And so I often have substantive conversations about the avoidance of bladder irritants. I really focus on irritants if their predominant symptom complex hedges more towards what we would call storage urinary symptoms. So things that are a function of how well the how well the bladder holds the urine, as opposed to voiding urinary symptoms or how well the bladder empties the urine. And so these are symptoms like urgency, frequency, nocturia, whereas the voiding symptoms are things like weak stream, intermittency, hesitancy, long voiding times. So if someone has really bothersome urinary frequency, urgency, or maybe they even have urge incontinence, where they have a strong urge to rush to the bathroom and they leak urine before they can get there, we go through potential bladder irritants. So coffee is a big one, tea is a big one, soda. I feel like I'm seeing a lot fewer crazy Diet Coke abusers than I used to, but I used to see patients that would drink like 20 Diet Cokes in a day. But coffee is a really big one, and people forget that the half-life of caffeine is 7 hours. So if you're having an afternoon cup of coffee, that can actually be associated with your nocturia. And so it's really important to understand not only sources of caffeine in the things that people drink, but also the half-life of caffeine in coffee and tea. People also forget that green tea is caffeinated tea, so that's just an important reminder. Alcohol. So alcohol is problematic for 2 reasons. Number 1, it's a bladder irritant. Number 2, people predominantly drink alcohol at night. So if the main symptom that someone is complaining of is waking up at night to void, alcohol is often a culprit, irrespective of what type of alcohol. Tobacco can be a bladder irritant. And then I talk about certain foods, and I think it's really important to talk to patients about this is not an end-all be-all, and this is not an absolute rule, but I always advocate for self-experimentation. And so some foods that we classically highlight as bladder irritants are things like spicy foods, citrus beverages. There are certain things that we think are not associated with irritation, like broccoli and onions. In general, I think it's a good rule of thumb that anything that promotes GERD or an acidic stomach is also likely to be a bladder irritant. But if someone just loves spicy foods, what I advocate is, gosh, just do a 2-week trial where you try to limit the number of spicy foods you eat and see if that's associated with a reduction in your symptom complex. And so here is where you're kind of asking the patient to do some soul searching about which of these irritants are really important to them. Is it so important that they have that glass of red wine at the end of the day that they're just going to tolerate waking up at night twice to void? Then that's their prerogative. But I also advocate some self-experimentation. So what are some of the medications we use for urinary symptoms? We would classify these broadly into two categories. And one I would say is sort of a channel opener, and one is a size reducer. And the channel openers are the alpha blockers. These are things that are smooth muscle relaxants, which most of the ones we use are ones that are focused on the smooth muscle of the bladder neck and the prostatic urethra. So these are things that are uroselective, and it looks like the N under Flomax got cut off. But the main ones you might use or read about are Flomax or tamsulosin. That's been available as a generic for a number of years now, so most patients are getting tamsulosin. Alfuzacin or uroxetrol. Those are the 2 most commonly prescribed uroselective alpha blocker medications. I can talk about bladder training a little bit because I'm going to talk a little bit later about overactive bladder, and bladder training is more related to overactive bladder. So if I forget, bring that question up again. Rapaflo is a newer drug that also is supposed to be uroselective. One thing I found about Rapaflo is for most payers it's very expensive, so I haven't found myself using that drug as much. Cardura or doxazosin and Hytrin or terazosin are less selective. So those are drugs that are more likely to cause orthostatic hypotension, so lightheadedness with standing. And so in general, we prescribe all of these medications at night so that if they do have lightheadedness, they usually sleep through it, or headaches. With uroxetrol, Flomax, and Rapaflo, you don't have to titrate up these medications, but because doxazosin and terazosin are less selective to the urinary tract, we typically start with a low number and titrate up to a max of 8 milligrams for doxazosin and 10 milligrams for terazosin over the course of a couple weeks. I use a lot of tamsulosin. I think a lot of providers too, because it's uroselective, but it's generic. And so I will say the commonest side effects that I see for tamsulosin that prompt patients to stop using it are related to sinus pressure and sinus headache, which affects about 4% of men. And it can give you really profound headaches, and that can be really bothersome to men. Importantly, all of these drugs are known for causing retrograde ejaculation. So I usually mention it to patients, and you just want to be wary about a younger man who's actually trying to achieve a pregnancy. And so it is reversible, so once they stop taking the medication, their ejaculation comes back. The two drugs below are 5-alpha reductase inhibitors, so they block the conversion of testosterone to dihydrotestosterone, which shrinks the stroma of the prostate and functionally shrinks the size of the prostate. So in general, if a man has been on one of these drugs for 12 months, their prostate will decrease in size by about 25 to 40%. So it's not a massive reduction, but it's enough that it can be associated with symptom improvement. The magnitude of symptom improvement with these drugs is not as high as the magnitude of symptom improvement that you see with the alpha blocker medications. And because they work by shrinking the size of the prostate over time, whereas with Flomax, you can tell a patient they would expect to see symptom benefit within a week. With these drugs, you say it's going to be 3 months to 6 months until patients see some symptom benefit. But they're really fantastic medications for mild lower urinary tract symptoms. And the clinical trials of finasteride did show a significant reduction in urinary retention episodes and need for surgery among patients taking chronic finasteride therapy. A reason we don't use these drugs as much in 2017 as we used them in 2007 is that there were 2 very large-scale preventive trials that evaluated the ability of finasteride and dutasteride to prevent the development of prostate cancer. Those are called the prostate cancer prevention trial for finasteride and the reduced trial for dutasteride. And both trials showed a 25% reduction in the risk of developing prostate cancer in men taking these medications. However, it also showed a 15% increased risk in developing a high-grade prostate cancer among those men who were diagnosed. So these drugs now have a black box warning from the FDA that you have to counsel men about their risk of prostate cancer associated with its use. So it's much less common that we use these medications these days, but they can be very effective. The other scenario in which they can be very effective because you're using them more for short-term benefit is when a man has refractory hematuria or blood in the urine related to an enlarged prostate. So this is a man who presents with blood in the urine. They have been fully evaluated, so you've ruled out serious causes like kidney cancer, bladder cancer, things like that, and your presumptive source is that they have an enlarged prostate. Well, actually, both of these drugs can be incredibly effective at decreasing bleeding related to BPH. So we talked about some of the side effects. The big thing that I did not mention with the alpha blockers, and the one you see it with most, which is tamsulosin, is use in cataract surgery. So there's this thing called floppy iris syndrome, where any tamsulosin exposure within almost a year of consideration for cataract surgery can be associated with a devastating failure of the cataract surgery because of this floppy iris syndrome. So we used to not know, I'll answer that in just one second. We used to not know about floppy iris syndrome, but now it's a really important consideration, especially because a lot of these men are older and they're concomitantly considering management of cataracts as well as management of BPH. In terms of which one of these medications, going back to this slide, which one of these medications works better? The question is, which one of these BPH medications works the best? So looking at the alpha blockers, the alpha blocker medications are associated with a more pronounced symptom reduction than the 5-alpha reductase inhibitors. So as your first line of therapy, you're going to start with an alpha blocker medication. In terms of comparing within alpha blocker medications, there are really no great head-to-head data. So for example, when Rapaflo was tested as a new drug, because it's relatively new, it was tested against placebo. It was not tested against tamsulosin, which is unfortunate. And so my impression is that these drugs all work the same. What they have are different side effect profiles. And so to try to use a uroselective medication that's also cost conscious and cost aware, my go-to first line therapy is tamsulosin. And I think that's true of most urologists and actually most primary care doctors or primary care providers as well. In terms of the side effects of 5-alpha reductase inhibitors, because these impact the conversion of testosterone to its byproduct and end effector dihydrotestosterone, it can cause sexual dysfunction. It's less likely to cause erectile dysfunction. The main thing we see is loss of libido. And it can be marked. It can be a complete and total elimination of sexual desire and sexual interest. And that happens in about 5% of men. And when it happens, it's usually so bothersome that it's a reason that men stop taking the medication. And we talked a little bit about the association between these drugs and prostate cancer. What about complementary and alternative medications? Patients ask about this all the time. So there have been an unfortunate dearth of high-quality comparative effectiveness research studies looking at phytotherapeutics, nutraceutical medications, or other non-conventional therapies for BPH. There have been a couple randomized controlled trials for saw palmetto and stinging nettle, which were actually placebo-controlled, double-blinded, randomized controlled trials, which showed no benefit for those medications over placebo. My spiel for patients, because I have some patients that swear by saw palmetto, and my spiel is it is unlikely to hurt you. And so if you feel that this medication is of benefit to you, it's unlikely to harm you, and I'm happy for you to try these medications or take these medications. So what about surgery? Well, there are some absolute indications for surgery, some relative indications for surgery, and some biases about surgery. The absolute indications are a man who's in retention and on BPH medications and still can't pee. So this is a man that presented to the ER, couldn't void, had a leader in their bladder, and you put them on Flomax, you put them on finasteride combination therapy, and they still can't pee, and they're not suitable for intermittent catheterization, or they don't want to do intermittent catheterization for life. Surgery is an absolute indication for that. Refractory bleeding due to BPH, a man that keeps getting recurrent urinary tract infections because their prostate inhibits their bladder emptying, and so they have stasis of urine in the urinary bladder. Any man that gets stones, so that means their emptying is so chronically retentive that minerals have precipitated out in their urinary bladder and caused them to form bladder stones. And 100% any man that comes in with urinary retention and acute kidney injury related to BPH and prostate blockage, that man is probably headed for a surgical operation. Backtracking 1 second, in terms of side effects of saw palmetto and stinging nettle, I haven't had patients complain robustly of side effects. Some of the preparations have different binders, and the binders can cause GI upset. Saw palmetto has been shown to have weak 5-alpha reductase inhibitor activity, so in theory it can also affect libido and sexual desire. Relative indications for surgery, really symptoms that aren't better despite medications, or a man's desire not to take medications chronically, which is a pretty powerful driver for a lot of men to consider surgery. What are the options for surgery? Well, the goal is really a plumbing goal. It's a mechanical goal to increase the size of the channel through the prostate. One thing that's confusing to a lot of people is how the urethra traverses the prostate. So if you think of the urethra like a tube, what is the relationship between the gland tissue of the prostate and the tube? But it's not a tube, actually. It's kind of a tube as it goes through the penis, where you have an inner lining of the urethra, you have a spongy layer around that, and then you have the rest of the penis. But as the urethra traverses the prostate, all you have is urothelial lining and gland tissue. So when we do something like a traditional roto-rooter or a transurethral resection of the prostate, or TURP, we're actually cutting into the lining of the prostate and then deep into the gland tissue of the prostate. And as that man heals from that surgery, their body is going to form a new urothelial lining over the defect that we created. And so anything that we're doing has an intended goal to basically make the channel through the prostate bigger. The gold standard is this TURP, and the way we do a TURP in 2017 is very different than we did it in 2007 or 1997, which is we do a bipolar TURP, and that's basically using a new technology to do an old surgery. So risks that that we saw back in the 80s and 90s of severe electrolyte abnormalities are just kind of no longer seen. But no matter what you use, if you use a fancy laser or a bipolar device, all men are going to have some bleeding after. And that's because even if you do a perfect job with, say, a laser, men are going to be left with this raw surface area inside the prostate. And so there's always this period of time after which maybe a scab breaks off, and they all have bleeding. And we typically expect bleeding to persist for about 7 to 10 days after one of these surgeries, but it can persist for a couple weeks, especially in men taking any kind of chronic, not even necessarily full anticoagulation, but men on Plavix can have problematic persistent bleeding, and even men taking a daily aspirin. A transurethral incision of the prostate is a more minimally invasive version. So instead of actually scraping out all of the prostate tissue, blocking the outflow of the prostate, instead what we do is we make a couple of incisions where the bladder and the prostate meet to essentially wing open that communication so that it's easier for the bladder to empty into the prostatic urethra. The Eurolift procedure is a new procedure that's been around for about 10 years, and it has 4 years of data. It's new here at UW literally in the last several months. And I have a picture to show you what that is, because it's kind of hard to understand what the Eurolift is unless you see it. It basically uses clips to pull the prostate tissue apart and effectively create a channel through the prostate without cutting any tissue. Because it uses these clips to pull the tissue apart, men can't have a median lobe, that ball valve that I mentioned before, that drops down over the opening of the bladder, because it's very challenging to figure out how to clip that so that you can get it out of the way. Open or robotic surgery is where the prostate is so big that it's too big for us to do any kind of scraping or laser or incision procedure. And what we actually have to do is we have to enucleate the gland tissue from the shell of the prostate, and that's called a simple prostatectomy. And I would say I do that once or twice a year. That's very rarely done. And we used to do that as a fairly morbid open operation, but now we do that as a robotic surgery, and it markedly reduces the bleeding associated with that operation. What are the outcomes of surgery? Well, frankly, surgery works really, really well. If you could fast forward men to maybe 6 weeks out from their surgical procedure, at that point, their bleeding has essentially resolved, and they're starting to see what their new symptom nadir is. And around 75 to 80% of men have a satisfactory improvement in their symptoms and their flow. But there are some side effects, and the two things that I see that bother men the most are the bleeding. It's always alarming to see bleeding, and it's important to remind men that a drop of blood in a bucket of urine turns it pink. So I always counsel men that they should expect to see punch-colored urine for 7 to 10 days. And urgency. So anytime you're creating this raw area that extends into the neck of the bladder, where there is a high concentration of sensory nerves, men are going to have a worsening of their urgency, especially if that was a symptom that bothered them before surgery, where now they're going to experience that same sort of sense of having to rush to the bathroom. Other big things that people always ask about, impotence and incontinence are very rare. It's important to distinguish this kind of surgery from prostate cancer surgery, where you're removing the whole prostate. And so we're not going outside the shell of the prostate where the erection nerves are. And you have a very easy visual recognition of where the sphincter muscle is. And so you're avoiding that with your surgical procedure. I always joke with men that this has a 5-year guarantee and a 10-year warranty. After 10 years, men can have regrowth of the gland tissue such that it's very common for them to need retreatment either with medical therapy or surgery. One thing that's really important to talk to men about with surgery is retrograde ejaculation. And for that reason, we often don't offer this to men who are younger. And that's because if you do a good surgery for BPH, you are almost guaranteed to cause retrograde ejaculation. The exception to that is with this Eurolift procedure. Because you're not cutting any tissue, there have been reports documenting rates of retrograde ejaculation with the Eurolift procedure less than 25%. Whereas I always tell men after a TURP that it's going to be more than 90%. It's kind of like this joke that if I haven't caused retrograde ejaculation, I worry that I didn't do a high quality surgery. Whereas with the Eurolift procedure, there can be preservation of ejaculation. Most men requiring these procedures are at a post-reproductive age, so they're not trying to achieve pregnancies. But a lot of men in their 50s and 60s care a lot about ejaculation, and so it's really important to talk to them about these risks. So the Eurolift, this is just a schematic showing you what we do. We do this in clinic, so it doesn't require anesthesia, which is nice, and they go home the same day, so it doesn't require a stay or an overnight stay, which oftentimes the bigger procedures like a TURP require. So what you do is you actually push the prostate gland tissue over and you deploy a clip outside the prostate, and as you pull back, you deploy another clip inside the prostatic urethra, and you can see that pulls the channel open. Typically we use 4 clips. For patients with a bigger prostate, we sometimes use 6 or even 8 clips. What about when surgery doesn't work? And it doesn't. So if the satisfaction rate is 75 to 80%, that means the failure rate is 20 to 25%. And the biggest reason really is bladder failure. I try to prognosticate that, and that's through understanding the risks for bladder failure and understanding what men are at a higher risk for having that as a complication after surgery. And those are men that you would want to do urodynamics on, because you want to prove to yourself that the patient is a candidate for some kind of outlet procedure. And the 2 biggest things I worry about are any man with long-standing diabetes or some long-standing neurological disorder. So I just saw a man who, in addition to his long-standing BPH, was just diagnosed with a Parkinson's-like syndrome. And he has been told he's no longer a candidate for a TURP procedure, which he's really wanted for a number of years because of this diagnosis of Parkinson's disease. And I actually disagree with that. Parkinson's can strongly affect urinary function, and the same sort of cogwheeling that Parkinson's patients get in their skeletal muscles, they can also get in their external sphincter, which can lead to sort of a pseudo dyssynergia and a retention. But that doesn't mean that that is this man's problem now. And so because this is a relatively new diagnosis and he doesn't have severe symptoms related to the Parkinson's-like syndrome, I think he's a good candidate for proceeding with the TURP. Another reason why it cannot work, well gosh, maybe the surgery was inadequate, and so maybe there was an incomplete tissue removal, or maybe the prostate was too big for what we planned to do, whether it was a Eurolift or a TURP, and that man needed something more aggressive and more invasive. It can also be that not enough time has passed. And so it's often my role to reassure men that they're still in the recovery phase of the procedure, and that we would expect continued improvement with time. And last but not least, and this is going to help us transition to the next topic where we are going to talk about bladder training, it's possible that this is not a prostate problem at all, but a bladder problem. So what are some other sources of urinary symptoms? Well, BPH typically causes, like we talked about, voiding urinary symptoms. Weak force of stream. That's the number one symptom that I almost guarantee men will get better with a TURP or one of these procedures. Hesitancy, that feeling of having to wait for the urine to come out. Long voiding times often plagued by intermittency and a sensation of incomplete emptying, or actually objective incomplete emptying. Those are things that probably will get better with one of these procedures. These storage urinary symptoms, though, can be a manifestation of a bladder problem, not a prostate problem. Things like urinary frequency, urgency, more even concerningly, urge urinary incontinence, dysuria or some burning with urination, and nocturia, which can be a very challenging problem to treat. So how do we manage overactive bladder? Well, we talked about behavioral things, avoidance of bladder irritants. I spend a lot of time talking with men about the timing and quantity of fluid intake. Our goal is not to make men dehydrate themselves. A lot of men do this naturally themselves in trying to reduce their urinary frequency or reduce their urinary urgency. And so there's this natural tendency toward dehydration, but I try to avoid that. What I talk to men about is figuring out a way to concentrate their hydration during the daytime when, say, bathrooms are accessible or waking up is not going to interfere with the restfulness of your sleep cycle and impair you the next day. And so what we try to do is concentrate fluid intake during the daytime hours so that after, say 5 p.m., men aren't as thirsty and don't require fluid intake going into bedtime. Men go into bedtime at different timings, and so what we always talk about is, gosh, you would be better off if you had a routine where you went to bed at a consistent time every night, because then you could back off of that. And let's say you go to bed at 10 o'clock every night. I kind of have this 4-hour rule that if you backed off 4 hours and said, I'm going to try to markedly restrict how much I intake after 6 p.m., that would be associated with a pretty impressive reduction in nocturia in general. So what is bladder training? Bladder training is more something we try to use for men whose predominant complaint is urgency. When men have urgency with urge incontinence, bladder training can be really difficult. And I think it's important to be realistic about bladder training. Sometimes bladder training is not possible until we do something to help men empty their bladders better. So if a man comes to see me and they pee every half hour or every 45 minutes to an hour, we can talk about bladder training a little bit. But if part of their symptom complex is incontinence, that's going to be very hard to achieve, because that man knows if they try to hold their urine, they're at risk for an incontinent episode, and that is really severely bothersome to their quality of life. But I do try to combine bladder training if we are going to put men on medical therapy for their overactive bladder. And the concept of bladder training, and this is how I explain it to patients as well, is you are trying to decrease your bladder's responsiveness to minor stimuli. So as we get older, two things happen with our bladder which are detrimental in opposite ways. Our bladder squeezes less well, so when we want to use it, it doesn't empty as well. But then it also develops hyperactivity, so sometimes it squeezes when it's not supposed to. So when you want it to squeeze, it doesn't squeeze as well. When you don't want it to squeeze, it has these spasms. And so what you're trying to do is you're trying to train your bladder not to be so responsive to these spasms. And in general, we try to increase the goal of bladder training concordant with the progression of their symptoms. So let's say I see a man who has overactive bladder who pees every hour. I put that man on a bladder relaxant medication, and we'll talk about those in a second. And then it seems like it's working. And now we want to combine that with bladder training toward maybe an initial goal of going 2 hours between voids. But I always counsel that man that if he has a fear of pain or a fear of an accident, that he should not try to persist in getting to that 2-hour time mark. It's just not worth it. And then ideally, if we can get that man to void every 3 hours, that usually is associated with a really positive quality of life. So what are some medications we use for overactive bladder? Well, there are medications that are easy to get and medications that are hard to get. There are medications that are associated with notable side effects and medications that have a better side effect profile. As you might imagine, the medications that have a better side effect profile tend to be harder to get. And most payers have you go through a stepwise tier system in how you prescribe these medications and how you obtain them. And so I want to go through a couple of these, and then I want to talk about what most payers make you go through in terms of your sequence of these therapies. So the tried and true medication in this category is oxybutynin, whose trade name is ditropan. So oxybutynin is a non-selective anticholinergic, which means that because of its non-selective nature, it's going to have robust dry mouth and dry eyes. And that's probably the most bothersome dose and medication limiting side effect for those medications. If they have that, it's also an excuse to transition to a more bladder selective, bladder relaxant medication. But those are not as potent as oxybutynin. So oxybutynin is a good place to start, not only because you have to, but also because if they don't have those side effects, or they are not bothered by the dry mouth or dry eyes that occur with oxybutynin, it works really, really well. One challenge with oxybutynin is that a lot of men who are going to need this medication are over 65. And so because of that, we worry about cognitive side effects. And that's going to be true of all of these anticholinergic medications. I'm going to take a quick moment just to answer the question about Kegel exercises. So what are Kegel exercises? Kegel exercises are pelvic floor strengthening exercises. And in general, when men have overactive bladder, that is not a pelvic floor problem, that is a bladder spasm problem. So we advocate Kegel exercises a lot for men who have stress urinary incontinence, which is most common after prostatectomy surgery for prostate cancer. So as part of any prostatectomy recovery plan, men are encouraged to do Kegel exercises to strengthen their pelvic floor muscles. But Kegel exercises are unlikely to help a man with overactive bladder and urge urinary incontinence, if that makes sense. So the more selective medications are these medications like tolterodine or Detrol, solifenacin or Vesicare, and darafenacin or Enablex. And depending on the payer, it's going to make you go through different tiers for these different medications. Trospium is a medication that also has some SSRI properties. So it's an antidepressant, anticholinergic medication that actually works really, really well and is a bit safer in older men. If a man has mild overactive bladder symptoms but is bothered sufficiently that they want medical therapy, trospium is a really good option, but most payers have it as a tier 2 drug, which means you have to still start with oxybutynin first. I want to focus on this others list on mirabegron, or that's a typo, Myrbetriq. And this is a medication that's actually a beta-adrenergic agonist. It does not interact with any of the cholinergic pathways for bladder contractility. And so because of that, it doesn't have some of the side effects that we see with the anticholinergic medications, dry mouth, dry eyes, and potentially the cognitive side effects. And so it's actually a very desirable medication for a lot of patients that we want to put it on. The problem with this medication has been, in my experience, access, but hopefully that will change with time. I mean, it's just because it's hard to get that medication as first line. And so oftentimes you have to go through these other medications first to get mirabegron approved. And then for many payers, it's a very costly copay. So it's been a problem related to expense and access, but it's a really important medication to know about, especially among older men. So how is OAB management different in men than it is in women? Well, the big difference is women don't have a prostate. So women have a 3-centimeter urethra that is rarely obstructed by anything. And so even when women have really severe overactive bladder, they must always empty their bladder well. But because a lot of men with overactive bladder have overactive bladder that results from long-standing bladder outlet obstruction by their prostate, they have these problems that are in competition with each other. They have overactivity and bladder spasms, but when they go to empty, they can't empty their bladder sufficiently. And that's a challenge because the medication we use to treat the overactive bladder is going to impair contractility and make that emptying worse. So one of the risks of starting one of these anticholinergic medications in a man with incomplete emptying is promoting retention. We used to be very paranoid about this, and now we are much more relaxed in our approach to elevated PVRs. But I would advocate following very closely any man who you're starting on an anticholinergic medication or mirabegron in the setting of BPH and bladder outlet obstruction, and definitely in the setting of an elevated post-void residual. This concordance of BPH and overactive bladder is very common, and what people don't realize is that overactive bladder is just as common in elderly men as it is in elderly women. The other thing I want to highlight is nocturia. So nocturia is probably the #1 reason why men are referred to see me. I think urologists in general for bothersome urinary symptoms. Usually if someone has daytime only urinary symptoms, they can compensate for those sufficiently that they're not tremendously bothered by them. But when it's waking men up at night, that is really problematic and really impactful to quality of life. And it's important to recognize that nocturia is not just a function of emptying and BPH. It relates to hydration status, sleep quality. I mentioned earlier that I'm not afraid to send men for sleep studies if I think that's impacting their nocturia. I talk to a lot of men about sleep aids. I ask a lot of men to go out and get melatonin, just because sometimes what happens is they're a light sleeper, and that light sleeper nature makes them wake up in the night. And if we wake up in the night, our body thinks we're awake. So it's immediately going to make us feel an urgency to void. And so disentangling waking up because an urge to pee woke you versus waking up and peeing is really challenging. And the other thing I am mindful of are other medical problems that can impact hydration status and nocturia. One of the biggest ones is cardiovascular disease. So a lot of men who may be more stagnant or not very functionally active might pool either clinically apparent or non-clinically apparent lower extremity or peripheral edema. And then when they're supine in bed, they reabsorb a lot of that fluid and they actually make more urine at night. Now, this concept of making more urine at night is common as we get older anyway, and then if it's exacerbated by a comorbid health condition, that can make nocturia really bothersome. And so we try to coordinate with primary care providers to make sure that we're doing everything we can to manage all the conditions that might be associated with nocturia. If a man has overt CHF, then what we talk about is elevating their legs for a couple hours before bedtime, and that sometimes helps reduce the burden of their nocturia. This is just a urodynamic tracing, just to show you what urodynamics produce. So on the top line that says PVES, that's the line in blue, that's the pressure we measure in the urinary bladder. The next line in green is the pressure we measure in the rectum. And then the line that's two below that, also in green, that says PDET, that's the subtraction of the two. So that's the pressure we measure in the bladder minus the pressure we measure in the rectum. So what we extrapolate to be the true pressure from the actual detrusor muscle of the urinary bladder. And so if I see that pressure go sufficiently up in the setting of a flow rate that is sufficiently blunted, that is consistent with bladder outlet obstruction. The EMG we don't use very often. Is BPH genetic? Is that the question? Or is overactive bladder genetic? I'm going to continue while you think about that. The EMG is sometimes used to look at what is happening with the external urethral sphincter. And so there's this disorder where patients have a dyssynergic bladder squeeze and sphincter. And so you can see if there's a problem with the sphincter relaxing as the bladder is squeezing. That's rare, and we hardly ever use EMGs anymore. In general, I use urodynamics to confirm bladder outlet obstruction, evaluate bladder contractility, and really look at the capacity and compliance of the urinary bladder. So I have a couple cases that I just wanted to highlight some patient decision making, and then I'm happy to take some questions. So overactive bladder is more likely to be genetic in women. In men, it is often an acquired condition from long-standing bladder outlet obstruction, but BPH does tend to be genetic in men. So BPH and bothersome urinary symptoms are much more common in men who have a first-order relative who also has BPH or bothersome lower urinary tract symptoms. So we often hear a story where a man knows that his dad had long-standing urinary symptoms and had some prostate procedure 20 or 30 years ago, and then their brother is having emerging symptoms themselves and is considering, medications or having surgery done. So this is a 62-year-old male, which is relatively young for severe urinary symptoms, who has recurrent squamous cell carcinomas, which are associated with some genetic syndrome that he and his twin have. His twin also had a spermatic cord liposarcoma, and he presented himself with urinary retention and acute kidney injury. So he has a documented baseline creatinine from 6 months ago of 0.9, and on presentation with urinary retention has a creatinine of 3.8. On admission to the ER, he has a CAT scan, which is a non-contrast CAT scan, which shows impressive bladder distension, but also bilateral hydroureteronephrosis, so dilatation of the kidney as well as the ureter all the way down to the bladder. So that's consistent with retention and pressure in the bladder backing up the kidneys and causing acute renal failure. So this is a case of an absolute indication for intervention. So in this patient, what we would do is put a Foley catheter in. In general, we monitor that patient in the hospital for a day or two to confirm that their creatinine is declining. And then you also worry about what's called post-obstructive diuresis, which is this idea that now that you've unblocked the bladder, they can get this diuresis that can cause electrolyte abnormalities. If someone comes to my clinic in urinary retention, but they don't have associated kidney injury, we are not going to observe them for post-obstructive diuresis unless they're worried that they can't keep up with their hydration needs over the next 24 to 48 hours. But in this patient who came in renal failure, we're going to observe him and make sure that his creatinine is declining, and also check a couple of electrolytes over the next 24 hours to make sure we don't need to replete their electrolytes because they're in post-obstructive diuresis. And then they're going to go home either with a Foley catheter, or we're going to teach them how to do intermittent catheterization. He subsequently underwent a transurethral resection of the prostate. And I actually saw this gentleman, he's now actually 30 months out from surgery, and his creatinine is 1 to 1.1, and he's voiding well with low post-void residuals. Here's a different example. This is an older gentleman who is mostly wheelchair bound, who comes into my clinic from his assisted living facility and has bothersome urge urinary incontinence. And we tried a panoply of different sort of trial and error medications. We tried doxazosin and tamsulosin in order to maximize his emptying, thinking that if his urgency episodes are happening as he gets to full bladder fullness, then if we can promote better emptying, we can at least decrease the frequency of urgency episodes by increasing the time between voids. And then on top of that, by maximizing his emptying, we also tried to maximize his bladder relaxant medications, but had no improvement. So monotherapy, combination therapy, a bunch of different trial and error, and we weren't able to achieve the benefits that we hope to see with his symptom burden. His main complaints when you talk to him are urgency and then going to the bathroom frequently, both day and night. He also has some concomitant voiding symptoms. So this is a patient who I would classify as having mixed lower urinary tract symptoms. And so this is a patient who I thought was a great candidate for urodynamics. So on this tracer, you see on the top tracing the pressure in the bladder, the second tracing the pressure in the rectum. So you can see he's not squeezing his stomach muscles at all to void. So all of the pressure that we're recording is coming from his bladder. And then the tracing below that, which just shows a teeny tiny blip, is his void. And so he is generating massively high pressures with intentional voiding. So this is consistent with really robust urodynamic evidence of bladder outlet obstruction. And so there's this nomogram that calculates what's called a bladder outlet obstruction index from the urodynamics. And it's the product of the pressure in their detrusor muscle with voiding and the flow rate. And so you can see if you have very high pressure but very low flow, that puts you in this obstructed category. He was very confidently in this obstructed category. So we actually did a TURP as our next line therapy. We did a transurethral resection of the prostate. Now, because we were able then to facilitate much improved emptying, we were able to put him back first on oxybutynin and then on tolterodine. And actually, initially, this is an outdated slide, I'm sorry, but he initially had some rare urge incontinence episodes. But I've seen this gentleman back more recently, and he now has no urge incontinent episodes and fairly good control over both his daytime and nighttime urinary frequency. So by diagnosing him with bladder outlet obstruction, we were better able to treat a predominant contributor to his symptom complex, and that allowed us to better manage his storage lower urinary tract symptoms with medical therapy. So we weren't able to get him off medical therapy altogether, but we were able to get him to a point where medical therapy actually worked better than it was before. So I wanted to talk briefly about a couple biases and then take any questions that you may have. So I'm a big believer in medications for BPH. I think an initial trial of alpha blocker medications, which are my kind of first line go-to medication, is reasonable, if not preferred. It's important to keep your expectations moderate. So one thing I often tell people is that when you take medications, it's going to make your symptoms better. Is it going to make them so much better that you don't feel bothered by your urinary symptoms anymore? I hope so, but not commonly. The 5-alpha reductase inhibitors can be used synergistically with the alpha blockers. So there is some evidence that those two categories of medications work better together than either alone. But this discussion of the prostate cancer risk is really important because it is legitimately a black box warning. And that is a big reason why we don't use those medications as much anymore today as we used to. This is a bias that's new for me. from how I approached this problem in training, and that is greater discussion of surgery in the initial consultation. And that's simply because surgery makes men a whole heck of a lot better than medications do. And so my bias is really strong when it comes to young men. And so by young men, I mean men in their late 50s and early 60s. And the spiel I often tell them is, it's very easy to get caught up in what your symptom burden is now. But I also manage the men who are 70 and 80 with bladder failure because of long-standing bladder outlet obstruction. And so it's really important to be mindful of where you want your urinary quality of life to be when you're 70 and 80. And so I want to have a long view towards men's urinary quality of life. And so I do at least have a discussion about surgery up front, because I think it's important for men to at least understand those options. And then really importantly, it's important to be mindful of other sources of urinary symptoms in men. Not all urinary problems in men are because of the prostate. And so if you at least have a mindfulness about that, you'll be more attuned to other sources of bothersome urinary symptoms. That's it. So I'm happy to take any questions. So the question is, in your opinion, would this kind of therapy, sort of water flowing nearby, help stimulate more regular urine flow? So can you use external triggers to help initiate urinary flow? We often hear the actual opposite of that. So we often hear about men who have overactive bladder symptoms, that some of the triggers that stimulate them to have urgency episodes that cause them to rush to the bathroom actually cause them to have symptoms. If a man has a lot of hesitancy, which tends to be a bigger problem at night, turning on the faucet and running a little water can often stimulate them to void. And it's not harmful except for wasting water. So I think that's a perfectly reasonable thing to do. Can BPH be prevented? That is a challenging one, because the answer is, in general, no. There was some thought for the prostate cancer prevention trial that not only were you going to see a reduction in the number of cases of prostate cancer, but you were also going to see a marked reduction in the number of cases of symptomatic BPH, which is probably true. So if a man took finasteride chronically who had a strong family history of BPH, it would probably keep them from developing symptomatic or clinical BPH. But because of the black box warning, that's just not going to be implemented routinely in practice. Maybe saw palmetto might be a good alternative to try in that circumstance. Imipramine is still available, but hard to find. And so I will say one of our providers here who mostly sees female patients used to use imipramine a lot. And now has a lot more difficulty acquiring imipramine for their patients. It's actually a really great drug in women because there is some evidence that it not only helps with the overactive bladder symptoms, but it can also help with stress urinary incontinence symptoms as well. So it can be sort of a two birds with one stone. The other question, and thank you for the kind words, was about the index that we talked about based on the urodynamics. And that is the BOOI, or Bladder Outlet Obstruction Index, which is the cross product of the pressure in the bladder with voiding and the flow rate with voiding. I'm trying to keep up, but it's rolling.
Did you get the genetic question was about overactive
Overactive bladder, yeah.
You got that. Okay,
Yeah.
Then there's one here. Many years ago, I was working with an elderly bilateral BK amputee with diabetes to help him with his urine flow at night. We set up a small fountain next to his bed. In his case, the simple sound of water flowing nearby worked wonders.
Yeah, I mean, I think that's more likely to be helpful in a man whose main problem is initiating the urine stream, which is very common in diabetics. So we didn't talk about this, but the classic profile of the quote-unquote diabetic bladder is a sensory neuropathy, so they don't feel bladder fullness. So oftentimes men with long-standing, especially poorly controlled diabetes, have bladder capacities over 500, over 700 milliliters. Because they have this sensory neuropathy, they don't feel when their bladder is full. So oftentimes one of your main roles is to actually do timed voiding. And instead of the 2 voids they have during the day, get them to void every 4 hours on the clock. And then when they do go to void, they also have a hypotonic bladder. So not only do they not feel when they're full, but they also can't generate a great detrusor pressure when they actually want to intentionally void. Tadalafil. So that is a great point, and I should add that to the slide. So there is some evidence / marketing around daily use tadalafil, which is also Cialis, for lower urinary tract symptoms. So the trials that looked at daily use Cialis for lower urinary tract symptoms did show some symptom benefit. In general, I think that would be better for a man with mild lower urinary tract symptoms. It did show a more pronounced and robust benefit in erectile dysfunction symptoms, which you would expect. Cialis is long-acting. It has a half-life over 24 hours, and so it's the sort of spontaneity ED medication. And so taking a daily use Cialis is going to help promote erectile quality irrespective of what time you're trying to have intercourse or masturbate. But in terms of urinary symptom reduction, it's nowhere near the benefit that you would achieve with something like tamsulosin. So I do use daily use Cialis occasionally, but more in patients with mild lower urinary tract symptoms. So stroke patients fall into line with a lot of patients with CNS disorders. So there are a number of different phenotypes of neurogenic bladder. So neurogenic bladder being bladder problems with some actual neurologic diagnosis. So, in a man or woman, in this case, who has something like multiple sclerosis or one of the spina bifida complexes or a spinal cord injury, that's going to give you what we more commonly think of with a neurogenic bladder, which is a bladder that just doesn't squeeze. So those are patients that you need to figure out how to help them empty their bladders because they commonly can't on their own. And so they either can learn to Valsalva, or they have to learn catheterization, or if they have deterioration in the functional status of their manual dexterity, then you have to think about chronic indwelling catheters. And so our largest sources of patients managed with chronic indwelling catheters are spinal cord injuries and MS patients. Stroke is a little different. Stroke tends to cause more hyperactivity because it's above a certain level in our CNS. And so they tend to get more pronounced overactive bladder symptoms. And so that is a situation where you're often balancing detrusor hyperactivity and impaired contractility, which can be very challenging to manage.
Any questions here in the room?
I do. I understand you talked about how Flomax is Euro-specific, but can you speak a little bit about its use in post-MI or patients with angina? Is there any concerns there?
And can you repeat the
Yeah,
question?
absolutely. So the question was about using Flomax in people with a cardiovascular event, so post an MI or post, I guess, even like a cath or something like that. I've never had that question, and I haven't had that come up as a concern. In general, I always tell patients that Flomax is really safe, and I haven't had a cardiologist ever ask me to stop Flomax because a patient had unstable angina or just had an MI. So I haven't had that problem. Is there a specific concern you have about that?
I just read a little bit in the literature about its safety in those patients.
Oh, wow. I'll look into that. So that'll help next year's class. Anything else? Okay.
Can I ask one more?
Absolutely.
So I know some of the language has moved from hypertrophy to hyperplasia. Can you explain a little bit as to why?
Yeah. So the question is about the terminology related to BPH. Thank you very much. And whether that's benign prostatic hypertrophy versus benign prostatic hyperplasia. And that really is, they're still both used. In general, that's why we commonly say BPH, so you don't have to make that distinguishment. But one is a clinical diagnosis and one is a pathological diagnosis. And so hypertrophy is just enlargement, and that's a clinical diagnosis. And hyperplasia is an enlargement of the glands within the prostate, and that's a pathological diagnosis.
You're growing more cells.
The cells themselves are larger, the glands are larger, and so that's a pathological diagnosis. So they're still both used, but in general, most of us just say BPH, so you don't have to disentangle that.
Thank you.
That's a good question. Okay.
All right. Thank you very
so much. I really appreciate it.
That was great.
Thank
Thank you very much.
Really appreciate it. Thanks for
Learned
the
a
great
lot.
questions.
Thanks
I'm
so
gonna
much.
I'm gonna look into the Flomax MI thing. I've never heard that before.
Thank you.
But